welcome to Leading Organizations That Matter, a podcast about leadership, organizational culture, and how we find meaning and purpose in our work. I'm your host, Ray Spadoni, former healthcare CEO, current consultant, author, and speaker. Today's topic is the pros and cons of Medicare Advantage. If you've seen the title of this episode, you'll recognize that this marks a bit of a pivot for us here on the podcast. Allow me to break the third wall for a moment and discuss the podcast itself. For the past 40 episodes, it's just been me offering a brief thought or two on a topic of interest for those who lead mission-driven organizations. Thank you to everyone who has been listening. It has been fun receiving your questions and feedback, and to be honest, seeing the numbers of subscribers and downloads increase week by week has been great, and frankly, pretty motivating. Today marks the beginning of the next chapter and introduces interviews with industry leaders and experts. There are a lot of interview podcasts out there that offer 1 or even 2-hour episodes. My goal here is to keep them shorter and more to the point, but of course, they are going to run a little longer than the 4 to 6 minute versions I've released so far. And the interviews themselves are going to be spaced apart, so you can expect to still receive the short dose episodes as well. Okay, so here goes. Today, I'm delighted to interview David Storto on the topic of Medicare Advantage. David's going to talk about what that is and then comment on it from the taxpayer, beneficiary, and industry points of view. David has over 40 years of experience and many major achievements in healthcare. He served as the president and long-term leader of the Spaulding Rehabilitation Network and Continuing Care Division of Mass General Brigham, the system formerly known as Partners Healthcare. More recently, David served as the Executive Vice President and Chief Strategy Officer of Tufts Medicine. Among his many distinguished achievements, David secured the funding and presided over the planning, design, and construction of the state-of-the-art and world-class Spaulding Rehabilitation Hospital in Boston, which opened in April 2023, just 12 days after the tragic Boston Marathon bombings. Under his leadership, Spaulding has consistently been listed by U.S. News and World Report as a top rehabilitation hospital, ranking as a top 2 or 3 hospital in the nation for the past several years. Spaulding is the internationally recognized home of Harvard Medical School's Department of Physical Medicine and Rehabilitation, and its residency program has been ranked as one of the best in the country. David is also a leader in the broader healthcare community and has served on a number of boards of directors and industry leadership groups. Trust me, his list of contributions and awards is a long one. Before moving to Boston, David was the executive VP and COO of the Rehabilitation Institute of Chicago, the #1 ranked rehabilitation hospital in the country since its inception of the U.S. News and World Report rankings. David received his bachelor's degree from the University of Michigan, a master's in social service administration from the University of Chicago, and a Juris Doctor from the Loyola Institute of Chicago School of Law. Okay, let's jump into it now. Welcome, David. Thank you for joining me on the podcast. It's great to have you here.
Thank you, Ray, for having me. Great to be here.
Good. Well, I'm looking forward to our topic today, Medicare Advantage. There's a lot that is said and written about the topic. It's been in the news, and on paper and at the highest level, it's an option for Medicare beneficiaries that makes a great deal of sense. I mean, what could possibly go wrong? So I think we're going to talk about the pros, the cons, how it influences our healthcare system, how it impacts subscribers. And so why don't we start with the very basics of what is Medicare Advantage? And, for someone as an enrollee or someone who's concerned about the larger policy issues of the healthcare system, what do they need to know about it?
Sure. As you said, Ray, it is an option for beneficiaries to go with a Medicare Advantage plan that is administered and managed by private insurers, unlike traditional Medicare that is just managed by the government. And Medicare Advantage is referred to as Medicare Part C often. Medicare Parts A and B are the basic traditional Medicare coverage, A for hospitalization, B for all other outpatient services. And then there's Medicare Part D that is for drugs, for medications. And beneficiaries have the option during open enrollment, by the way, which is just about to start, to participate in either a Part C Medicare Advantage plan or stick with Medicare, traditional Medicare Parts A, not Part B coverage, and then have to get a drug plan under Part D.
So from the government's perspective and from a policy perspective, why do they introduce this and what are they hoping to achieve?
They're hoping to achieve cost savings by having insurers manage care, as opposed to under traditional Medicare, there really is not a care coordination, care management function. There are criteria for different services to be reimbursed at different levels, but there really is no intervention by the government or any other third party to manage the care of a beneficiary. So privatizing, which is effectively what Medicare Part C does, gives the insurer the opportunity to manage care in a way that could result in more profits for the insurer. So under Medicare Part C, the government pays a per member per month capitated rate, as it's frequently referred to the insurer to manage the total cost of care for that particular beneficiary. It's risk adjusted and it's different, reimbursement levels depending upon the different parts of the country. There's a multifactorial kind of calculation that drives what's paid. But effectively, if the insurer is able to manage the care at an amount less than what they're being paid by the government, they win. If they end up, costing more than what the government is paying them to provide care, they lose.
Well, given the fact that the percentage of enrollees in Medicare Advantage has increased, is it safe to say that they have achieved their objective and that the federal government is completely backing this as an option?
Well, it's true. The now more than half of beneficiaries have opted for Part C plans. In terms of how effective it has been at reducing costs, I've seen different kind of reports and studies on what the real economic impact has been. And quite frankly, it's just not clear. I think for beneficiaries, part of the reason why more than half have opted in is because there are additional services that are provided, frequently dental, eyeglasses. There's lower copays for services. There may be no copays depending upon a plan. Lower premiums than if you stick with traditional Medicare under, a Part B plan where you do pay for that. So it's got all of those enticements for beneficiaries, and insurers spend a lot of money marketing these services. You probably have turned on a TV at some point in time and seen some celebrity that's been touting the advantage of Medicare Advantage, and to call that 1-800 number right away, to take advantage of it. So it's got those enticements, as I said, benefits that kind of go above and beyond traditional Medicare.
Well, the advertisements are compelling.
Yeah, they are.
They're very easy to be drawn into it. And so if you are Medicare eligible, or if you're planning for your own eligibility at some point in
Yeah.
time, or you're advising a friend, or maybe you're trying to help your own parents as they are evaluating the possibility of going the traditional Medicare route versus the Medicare Advantage route, what would you advise folks? And let's look at this from the beneficiary perspective. Is what really are the pros? Are the ads correct, or are there any cons?
Oh, yeah, there are cons. And the cons basically fall into one major bucket, which is under Medicare Advantage plans, care needs to be pre-authorized by the insurer. And there are frequently long delays in granting those authorizations for care. And there are frequently denials for provision of reimbursement for the services. So for the beneficiary that's basically healthy, doesn't need a lot of care other than, kind of preventive kind of care, and can take advantage of all those enticements that I talked about, it's great. They pay less and they get more. Yeah, now they get sick. They have a chronic condition. They have a physical disability as a result of a traumatic event or an illness, a stroke, and they need a wide range of services over the course of the rest of their life. Then Medicare Advantage's cons really surface in ways that are very, very problematic. And so problematic, obviously, for the beneficiary and their family, but also problematic for providers, for hospitals, for doctors that have this care of the person that they can't get authorization to go forward with, because they go forward without the authorization, they don't get paid. So that's the biggest disadvantage, and there's a lot more attention being paid to that issue now. Stat News has really kind of taken this on as one of their their poster kind of issues, and has written a lot about it. It's for me, coming out of a career that included a long commitment to rehabilitation medicine, it's particularly problematic because Medicare Advantage is notorious for denying claims and authorization for rehabilitation care for people, and it's very troublesome.
What's the recourse if you're a beneficiary who needs, for example,
Yeah.
rehabilitative care and they deny me?
Yeah.
Am I stuck?
There's an appeal process. They vary somewhat from plan to plan. And there's different levels that you can escalate to. The final level is, well, I guess the final level is actually to sue, which has happened in some cases. But before you get to that level, having a discussion from provider to provider, physician to physician, to review the need for the care, with the beneficiary's physician advocating for why they need it, to a physician who represents the insurer and ultimately decides, okay, are we going to overturn the initial decision based on this appeal, or are we going to stick with that decision? The problem with the appeals process, and the process is challenging, cumbersome for people that really know what they're doing. And because of the problem that's been created with the pre-auths, there is a level of expertise that's been developed to appeal. And the interesting thing is for people that really go to the mats and follow through this appeal process, the vast majority of them end up being approved, which begs the question about why should they have ever been denied in the beginning? And there's plenty of press about it. So any of the listeners here who are interested can, just go on Google and find all kinds of reports. But there's a lot now just about how algorithms are being used so that through multiple stages of the appeal process, you're not even really dealing with a human being. You're just dealing with an algorithm. And so, and there's reports of certain insurers that have really created pressure for their employees to abide by the algorithms, even when from a clinician's point of view, they feel it's inappropriate. And that has created, a lot of controversy in the field.
Well, that's fascinating. So if ultimately many of the appeals are approved and the initial decisions overturned, it feels as though it's a system that has been built to create friction so that, the care will be covered, but you got to work for it. Is
Yeah.
that too oversimplified a way of looking at
No,
it?
no, I think that's the nice, pithy, characterization. And unfortunately, there are plenty of folks and plenty of providers who just either don't have, the expertise, or even if they have it, have so many other issues that they don't go to bat. And so that person that might really, the person who's a 68-year-old stroke survivor that could really, that was otherwise basically healthy and could benefit from an intensive rehab, intervention, might wind up in a nursing home getting less intensive kinds of care and perhaps develop all kinds of other complications. And so the denial process actually works because not everybody does appeal.
Right. Is there a way, let's say I'm approaching Medicare eligibility and I say to myself, I've been in an HMO now for 30 years. I'm used to all this. This is the way HMOs work. And I now have an opportunity to pretty much stick with what I know. I'm pretty healthy. But when that time comes that I get sick, I'm going to surf the wave over and pivot into traditional Medicare so I don't have to deal with all this.
Yeah, yeah, yeah,
Can I do
yeah.
that?
Well, good question. And the answer is yes and no. And when it's yes, you can only do it during open enrollment. Um, so if you are unfortunate enough to have, a traumatic event or a sickness, early in the year after you've been on a Medicare Advantage plan, you're stuck until open enrollment. And then in certain states, if you have been on a Medicare Advantage plan and then you develop chronic illness or condition, in certain states, it's possible for all insurers who offer Medicare Advantage plans to deny your eligibility. Um, it's a handful of states. Um, and I don't want to mislead by, I think I definitely know a couple of them. Massachusetts is not one, by the way. But that's a real problem for that person that thinks, oh, I'm healthy today and I'll swap when I really need the traditional Medicare. And then they find out, oh my God, I don't really have that option anymore.
Wow. So it's it's a bit of a Russian roulette situation based on timing and your own health status. Um, David and I, by the way,
You asked me earlier, what I recommend to people. And,
yeah,
again, I will admit my bias. I think I've articulated what, some of these benefits are of being on a Medicare Advantage plan. Um, but when even healthy beneficiaries ask me for advice, um, I say go with traditional Medicare. It really is, it's roulette, like you said. And, you just have to kind of make your own choice based on your tolerance for the possibility that you're going to become ill and not be able to get the care that you need, or you may get it, but it's going to be, major hassle for you, your family, and your healthcare providers to get it.
do you have a sense at all, David, of what's the financial incentive to me as a beneficiary to play in the Russian roulette game? Because, presumably I'm going to look at a Medicare Advantage option and see a lot of benefits to it
Yep,
and
yep,
save some money versus
yep,
traditional Medicare with some kind of supplemental, plan
yep,
bolted onto the side of it. Um,
yep.
is it, might someone look at this and say, yeah, I'll play the slots here and see what comes up because I'm saving a ton of money. Do
Yeah.
people save a ton of money?
They say, I mean, I don't know how much a ton money would be. Um, and it's obviously all relative depending upon what one's, financial situation is. But, if you are at paying the highest amounts per month under traditional Medicare for Part B, it's 500 some bucks a month. Um, so, and then you're paying separately for a Medicare Part D plan for your drugs, which can be substantial if you're on high cost drugs, um, as compared to what you're paying in a Medicare Part C plan. Some of those plans also offer the drug benefit, by the way, which would be substantially less than that. Might be, a couple $100 a month. So, if you're a person who's in a position where you're making these tough choices about, how much food you can put on the table versus, you pay for your healthcare costs. Yeah, it's a very, very challenging situation for people. I think the other issue though is that most people don't really understand. I've talked to so many people, in my career that didn't even know they were on a Medicare Part C plan. They just, they saw the advertisement. They say, "Hey, yeah, looks good. I'm signing up for this because I get dental coverage too, and I got bad teeth, so I want to get that dental coverage." Um, so it, I don't have, uh, an empirical study to support this, but my hunch would be the vast majority of people sign on to Medicare Part C without understanding
Right.
what you and I have been talking about here about the pros and cons. They see only the pros, um, and they go for it.
There is seeming simplicity to this, but there is complexity lurking just below the surface. David, you and I have spent our careers working in an industry, and I'd like to just switch over now to the industry perspective if you are a healthcare provider. And that's
Yeah.
really for this podcast, leading organizations that matter, this concept of some organizations take the long view, they're very principled, they care for their, members of their community. What has Medicare Advantage done to those kinds of providers?
Interesting. It's actually the tide is turning a bit here. A lot of healthcare providers are dropping Medicare Advantage for a couple reasons.
Meaning they won't even take a subscriber who has Medicare Advantage. Is
They
that,
won't have a contract, and so they therefore will not provide care to, you know, Jane and John Doe who, were with a Medicare Advantage plan that the healthcare provider has discontinued. So, and is that happening? Well, one of the big reasons is what I would discussed earlier is just the pre-auth issues, the denials, and the administrative burden and cost associated with dealing with that, the longer lengths of stay that are, that result in an acute care hospital while a person is, awaiting discharge to, a post-acute provider, a rehab, a SNF, a home care organization, where they can't get the authorization timely. So it's imposing a lot of cost and burden on providers. There's also issues, and this is also getting a lot of attention, where the government is challenging some of the coding of some of these providers, typically referred to as upcoding and alleging upcoding in many instances that, has an indirect, economic impact to the provider. So it's interesting that, where it was at one point in time, just the cat's meow, if you will, particularly for health systems that really bought into the idea of value-based care, and managing care effectively, to, now many providers dropping out.
Well, going back for a minute to the enrollee, to the subscriber perspective, um, further restrictions to the network that's available to you of care. And if you have a relationship with a provider just by virtue of going into Medicare Advantage, unbeknownst to you, as you're watching the advertisements and making your choices, that you're going to have much more of a restricted network of care
Yeah,
that you can access.
yeah.
And it's almost impossible to know that at the point when you're signing up.
That's right. That's right. And even as you may wind up having a network that works for you, um, that could change on a dime. And how many people have you talked to recently that said, geez, I've had like 4 PCPs in 5 years? And
Mhm.
that's another issue, just the challenge of primary care and the challenges with access to primary care. So when you take that fundamental issue and couple it then with the reimbursement insurance complexity, it's really a sorry situation for many people. They're getting bounced around from plan to plan, physician to physician, network to network in ways that certainly fly in the face of the whole notion of continuity of care.
Well, speaking of continuity of care, and an area I'm familiar with, and I know you are as well, but in traditional Medicare for home care based services, um, individuals are given 30 days of care. Say they're coming off of a surgery or something
Yep.
and they need home-based care, and there's 30 days of care. And now in a Medicare Advantage plan, they'll be approved for 2 or 4 visits. Not only does that significantly impact the reimbursement to that home care provider, but it changes their identity. It changes the nature of who they are, because in 30 days of care, you're going to case manage. You're going to offer what you believe that patient needs most of all, which could include bringing in a occupational therapist or a home health aide or whatever you think that patient needs in order to meet the care plan goals and to have them move forward and to advance. Now you have 4 visits. And so for that home care agency, they're getting a lot less money to care for you. It's changing the identity of who they are, but also to go into the home and then to have a nurse say to someone who clearly needs a lot more care, this is my last visit, I have to leave. You're leaving a lot of frustrated behavior, provide patients rather behind,
Sure.
who don't necessarily understand that it's not that home care agency's decision to never come back to the home. It's based
Sure.
on what they've been approved for. And so I suspect there are corollaries in other aspects of the industry, but um, the question really then becomes for the industry, what becomes of this going forward? You mentioned that the tide is turning a little bit. As you see that happening and you look up ahead the road, what are the trends you see coming for Medicare Advantage, if any?
Well, I think as they face the number of, in many cases, major health systems opting out of Medicare Advantage, um, and as insurers themselves in certain markets decide they don't want to play either, just because a risk adjustment from their standpoint might not be sufficient, and they kind of they evaluate whether they think they can make this work profitably. So it's very tricky. I guess I would say that what is going to need to occur in order for Medicare Advantage to continue to flourish is various things that would mitigate the risk, both for the insurer as well as the beneficiary who's signing up. So that there is, there's new regulations that came into effect this year that would curb some of what might be characterized as an abuse around authorizations, making, certain timeframes in which they have to make decisions, which I think are still they're not restrictive enough. But I think more of that kind of thing will need to occur. But then, it's going to also then wind up costing the program, as much, if not more, because if they're, you know, if the providers, if the insurers are, taking a piece of the action, so to speak, that's costing overall, more for the Medicare program. So that's what I guess I see. Now, I don't, whether this will ever, the political debate, on the left with the Bernie Sanders kind of approach of Medicare for all versus, strong opinions, on more to the right about keep the government out of my life in every respect. And damn, I'm not going to give them, control of my health care, which is kind of facetious because to some regret they already do. but, um, but I don't know how that's going to play out. I don't know how that political thing is going to play out. Um, it's not been a political advantage to people like Bernie Sanders to have that perspective.
Well, you know, venturing into the political waters here, I mean, there are so many policy questions, and for all of the time that I've been working in the healthcare industry, there's always been challenges, there's always been change, but it feels to me as though over the past several years, and granted, we had a gigantic pandemic in the middle of
Yeah,
that, but staffing shortages, you mentioned earlier, the primary care shortages, the fact that it has become a very difficult profession for many clinicians who want out. And a lot of it has to
yeah,
do with the aggravation that's presented to them by the fact that there are all these insurance programs, and Medicare Advantage only adds to that because
yeah,
everyone's got their own requirements. Their patients are asking them to help with their appeals processes, and they're spending less and less time dealing with the issues that they were trained to deal with, which is the health and well-being of their patients. So we're adding complexity, and to the Bernie Sanders point, this notion of Medicare for all. And then you alluded to the fact that Medicare is being privatized to the tune of half of are now part of the insurance company. I'm not sure what Medicare for all is going to mean in the future if that's a trend that continues. It's there's a lot of
you know, in
policy
many
questions here.
in many respects, I mean, I think it boils down to you want to find ways to prevent overutilization of care based on, the old fee for service models where, the more you did, the more you got paid. And then at the same time, you want to prevent, underutilization and withholding of care because provider insurers economically incented to withhold care. How you strike that balance, and then, to some extent, if you think of it in context of the legal system, are you prepared to let, you know, nine guilty people go free to ensure that the one innocent person will not, you know, be incarcerated and prevented from going free? Um, I guess if you're talking to David Storto, while I certainly would not promote overutilization, um, I guess if I had to choose between the risks associated with that versus underutilization, um, I think the government can just pay a few extra bucks for the overutilization, because all the infrastructure and apparatus that's put into preventing that is costing a boatload of money too.
Well, as is often the case, it usually depends on from which perch you're observing all of this from. And if you are an extremely healthy person and you're doing fine with Medicare Advantage, you might think one way about it. But if you're part of this significant wave of aging population, and you're going to be experiencing health challenges in your life, Russian roulette is there's no game to be playing when you need care, you need good care, you need access to it. You don't want to get aggravation and delays dealing with appeals processes. Um, it costs a little bit more to go Medicare traditional, but I'm hearing from you, and I'm certainly sensing myself that folks need to pause and really think about this carefully and recognize that, there's no free lunches. You may save some money on Medicare Advantage, but, sometimes you get what you pay for.
Yes, sir. Absolutely right.
Awesome. This has been a great conversation, David. I appreciate it. This is the first of the interview series. I've been sort of going with short form, sort of 1 or 2 points per podcast. I've been doing it
Yeah.
now for a little over half a year, and I'm now
Yeah, and
moving
they're
to the next
great.
phase.
They're great, by the way. As you know, I listen to all of
Well,
them.
thank you. I appreciate that very much. I will tell you, it's a little addicting watching the subscribers go up and the downloads go up. It's been fun, but I'm very much looking forward to taking it to the next phase. And so I can't think of a better inaugural episode on a very, very important topic. So thank you very much for your willingness to be the crash test dummy on this podcast when it comes to the interviews. I know you're still very actively engaged in the industry. If folks are interested in learning more about you and the kinds of work that you're doing, how can
Sure.
how can people get in touch with you?
Email is my last name, Storto, Storto, 907 at gmail.com. And
Perfect.
my cell number is 617-759-7724. That's how to reach me.
And thank you for that. You're, being accessible. An expert in this field, and you're certainly an expert given your long history leading significant organizations in healthcare. Makes you a very valuable person. So thanks for being so accessible. I'll put that contact information for those of you who are driving and can't write it down. I'll make sure that's all in the episode notes. Drive safely, and and thank you all for listening. And again, David, thank you so much.
Thanks, Ray. Take care. Have a great day.
You too. Thanks for listening. I hope you'll consider leaving a 5-star review on Apple Podcasts or your platform of choice. That will help others find us here. My mission is to help empower organizations that matter by supporting those who lead them. Feel free to learn more about me and my work at redsaleadvisors.com.